So, more MLA conditions. So we're going to talk about Myasthenia gravis today. So most people have heard of Myasthenia gravis. It's an absolute travesty of a naming system because the doctor that named it mixed up his ancient Greek and his Latin. So it means serious weakness, but one word is Latin, one word is Greek. So sorry to any Greeks or presumably less likely Romans watching this. It's a neuromuscular junction disorder. So it interferes with the transmission between the nerve and the muscle and the acetylcholine that flows across the surface. It's the most common neuromuscular junction disorder, and it's a postsynaptic form. So it affects the receptors on the target membrane as opposed to the origin membrane. So the most common antibody that's associated with that is an acetylcholine receptor antibody. So if you find an antibody in myasthenia, and we'll talk about how sometimes we don't, about 3/4 are acetylcholine receptor antibodies. That's the common one, and MuSK is the rarer one. So we would find that in about 1/4 of the remainder. And sometimes there are very rare forms like striated muscle antibodies, but I'll not talk about those. So I've missed my M here, but myasthenia affects muscles of the eyes most commonly, and then the bulbar muscles, so the muscles of speech and swallowing, and kind of the head and neck for posture of the neck, and then generalized musculature. So you'd expect more people to present with eye symptoms, ocular myasthenia, then bulbar symptoms, bulbar myasthenia, but most would have ocular bulbar and then generalized. It would be strange to have generalized myasthenia with no eye or bulbar involvement, though I have seen it once or twice. And it is a condition of fatigability, not fatigue. So we get lots of referrals saying this person is very tired. Do they have myasthenia? What fatigability is that so we are constantly doing repeated motions with our muscles, and we do get tired over time with exertion, but we don't expect weakening of the muscle on a rapid basis. That's pathological. That's not right. So, for example, if you look up for a period of time, you don't expect the muscles to become so fatigued that they begin to droop, or you don't expect that the extraocular muscles that move your eyes around become so fatigued they just start drifting out in strange directions, and we call that complex ophthalmoplegia. So that's what fatigability is, so you can test for that. And that kind of leads into the history, the diurnal history. So generally people develop their symptoms as the day goes on or as an activity goes on. So they'll find that they're struggling to swallow if they have bulbar symptoms. They're all right at the beginning of the meal, but they sort of tire out and then they sort of start to choke a bit because the muscles of swallowing are fatiguing too fast. They'll be concentrating on writing a note, but then they'll find that they develop double vision because their eyes just become really tired really quickly. You know, if you do a night shift and you're absolutely exhausted, you can get slightly diplopic, but you wouldn't expect it just on a short task. And this is the sort of pattern that you'd expect to see. Okay. Examination, what you're looking for myasthenia is you're looking for ptosis, so drooping of the eyelids, and sometimes that can be complete ptosis, so the eyes are closed. You can induce that by having them sort of look up over a prolonged period, and then that can sort of bring about the ptosis. I generally do it in 30-second, 45-second, and 60-second blocks. Complex ophthalmoplegia, where the eye movements are affected, but not in a distribution that you can put down to a single cranial nerve. So, example, a third nerve palsy, you expect a down and out position with the pupils involved. You wouldn't see that with myasthenia. It's dynamic and variable because all of these muscles are trying their best, but they're sort of fatiguing at different rates, so it's variable. Pupils should not be involved in myasthenia. If the pupils are involved, it's not a neuromuscular junction disorder, so just bear that in mind. Slurred speech, so again, people will start off quite well, and then as they keep going, they'll find that they get more slurred, and that's because the bulbar muscles are fatiguing. And fatigable features on limb examination, I'm actually going to ask my noble cameraman to kind of come out, if that's all right. Could you?
It already is.
Huh?
It's already zoomed out, it's not zoomed. Oh, you mean, right, I see.
So, initially you would expect that somebody is strong, so if you just push down for me. Good, so nice and strong. And then you get somebody to do a repeated motion. So I always tell patients chicken wing, and then you'll find that someone has fatigued. Thank you, you will be credited. So axial weakness, so weakness of neck flexion or extension can be a surrogate for somebody having weak diaphragmatic muscles or intercostal muscles. And when I examine, I always do a breath count, so get people to count in one breath. 1, 2, 3, 4, 5, 6. Has to be out loud, has to be in one breath. And somebody who's young, without lung problems, you'd expect 30s to 40s. If somebody's single digits, they're in trouble. And if somebody can't complete sentences, they are in trouble. And you need critical care to help you. So here's a slide just showing you some eye movements in myasthenia gravis. So you can see that on prolonged up gaze, this lady has some left-sided ptosis. And you would expect that eye movement problems in myasthenia should be bilateral and symmetrical. Yeah, they should, but for some reason there's often a lot of asymmetry. So some people may have very predominant features on one side and mild on the other, or it might just be present in one side, so bear that in mind. So investigation. So I always say for myasthenia, sometimes when it's very vague and it could be a mild presentation and there's very little to find on examination, it's difficult to say whether or not this is myasthenia. If it's overt, if the examination is obvious and the history is obvious, then that's really helpful. But I always say you need 2 out of 3 for any sort of diagnostic clarity, for sureness. Convincing history and examination, so you find features of myasthenia when you examine. A positive autoantibody, and neurophysiology testing that supports myasthenia gravis. 2 out of 3 makes me pretty happy that I know what I'm treating. If there's one or none, then I'm less confident. And the neurophysiology that we use is repetitive stimulation. So exactly as we just did there with James, where I repetitively moved my arm and then it got weaker, we can do that neurophysiologically. So a single muscle is sort of stimulated again and again, and you would get decrement that we could demonstrate and show, and that's supportive of a diagnosis of myasthenia. And it also shows jitter as well because it's unstable. We also recommend CT of the thymus. Thymus is a weak gland in the neck. In adults, it should be vestigial. You should have lost most of it. But in myasthenia, some people have an abnormally swollen thymus, which can be cancerous, and that's often thought to be the source of some of the antibodies in some people. So we wouldn't want to miss a cancerous thymus. And in people that have bad myasthenia that doesn't respond to treatment, removing the thymus can get people into remission or at least improve things. Medication, we use pyridostigmine to help prevent the breakdown of acetylcholine in the junction. That's the kind of the first line treatment, and for some people that's enough. It can cause a little bit of diarrhea and vomiting, mainly diarrhea, and there are medications to help take the edge off that. Propanthaline we use specifically. We do use immunosuppressant therapy. Obviously we can't selectively suppress autoantibodies, unfortunately, that's science fiction as yet. But we do use prednisolone to try and suppress the immune response, and then we titrate up until we get resolution of symptoms, and then we keep on for a period of time, and then we try titrating down to see if we can get people into remission on as low a dose of steroid as possible, because long-term steroids can cause problems. If we cannot keep people with an acceptable level of symptoms on a low enough level of steroids that don't cause problems, if they're steroid toxic, when we use steroid-sparing agents. So these are your classical immunosuppressant treatments: azathioprine, methotrexate, mycophenolate, that sort of thing. And your IVIG and your plasma exchange, we don't tend to do that regularly for most people, but we do use it if people come in with an exacerbation. We need to treat them and get them over that rough patch, often after an infection or something like that. So myasthenia is an autoimmune postsynaptic neuromuscular junction disorder. Rarely it can be associated with a cancer of the thymus, for example, paraneoplastic. Treatment can be divided into your long-term management to try and get people into remission, and your acute management if somebody presents acutely with sort of breathing difficulties and they need admission to critical care, then you would use things like IVIG and plasma exchange, or if they came in an exacerbation. And it's critical that you support people with a critical care level of input, and as well as giving treatment like IVIG. Don't keep people on a ward if they're going into type 2 respiratory failure and give them IVIG and expect them to get through that. They need critical care support, and the IVIG will work over days or weeks. It can get really complex with conditions like myasthenia gravis if people have other conditions, or if they're pregnant, for example. I'll just leave that in the mix so you can think about how complex that would be, but certainly beyond the scope, I think, of the MLA exam. Thank you.